device that can give your heart an electric shock when it has stopped in a cardiac arrest. AED is short for Automated External Defibrillator. An AED can be used on adults and children over 1 year old. Using an AED in crucial minutes before an ambulance arrives can increase someone's chance of survival. Anyone can use an AED. You don't need to be worried about getting it wrong or causing harm because the machine analyzes the casualty's heart's rhythm and then gives visual or voice prompts to guide through each step. If someone is ask someone to call 999 or 112 for emergency help. Ask them to bring an AED if one is available. If you're alone, make the emergency call yourself on a mobile phone or speakerphone and start CPR with chest compressions. Do not leave the casualty to look for an AED. Keep doing CPR until someone brings an AED. As soon as the AED arrives, ask for it to be switched on while CPR is continued. It will immediately start to give you verbal prompts informing you of what needs to be done. If someone is with you, ask them to follow the instructions until emergency help arrives.
Call for help now. Remove all clothing from patient's chest. Pull red handle to open bag. Look at pictures on pads. Peel one pad off blue plastic. Apply pad to bare skin, exactly as shown in the picture. Press pad firmly. Peel other pad off blue plastic. Apply pad to bare skin, exactly as shown in the picture. Evaluating heart rhythm.
Stop compression, Susan. Stand back.
Stand by.
Stand clear, everyone.
Shock. Everyone clear. Do not touch patient.
Stand back.
Delivering shock. Shock delivered. Provide chest compressions and rescue breaths.
The AED will instruct you to continue CPR for 2 minutes before it reanalyzes. The AED could say no shock advised, continue CPR. If the casualty shows signs of becoming responsive, place them in the recovery position. Leave the AED attached. Continue to follow the voice and/or visual prompts that the machine gives you until help arrives. So remember, when using an AED, call 999 or 112 for emergency help. Continue giving CPR when the AED arrives and keeps going when the pads are applied, if possible. Ensure that the pads are placed on the chest after clothing has been cleared or cut away. Ask for the AED to be switched on and follow the instructions. Ask people to stand back when the AED is analyzing and when any shocks are being delivered.
Okay, for a while. Okay, for a while lang ha. Hanapin ko lang yung isang video. Okay, so we're done na po no, on the first part. So I'll be showing you a video regarding cardiopulmonary resuscitation according to Lecturio. Ito din yung pinapakita po namin sa aming trainees.
Once you start CPR, you want to really make it count because patients are much more likely to survive if you perform high-quality CPR than if you perform poor-quality CPR. And there are 5 major determinants of CPR quality, which we're going to discuss in some detail. The first is the rate of compressions. 100 to 120 is the rate that every rescuer should be aiming for. 2 is adequate compression depth. We want to go about 2 to 2.5 inches or 4 to 5 centimeters. 3 is continuity. You should be performing CPR for a minimum of 60% of your total resuscitation time, if not more. Fourth is chest wall recoil. That's diastole in cardiac arrest, and that's what allows the heart to refill. So we want to ensure that we allow the chest to recoil so the heart can fill normally, making each compression count. And last is hyperventilation. Hyperinflating the lungs decreases cardiac output and is another variable that produces adverse outcomes in cardiac arrest. So let's start with compression rate. There have been a number of studies looking at rate, and this is one example. In this study, they looked at the mean rate of chest compressions among a large sample of cardiac arrest patients, and they found that the patients who had compressions at a rate of roughly 100 to 120 had the highest probability of ROSCE, which stands for return of spontaneous circulation, and they also had the highest probability of survival to hospital discharge, or having a longer-term positive outcome, more likely to survive when we use that rate. Compression depth, we have a similar study looking at patients getting return of spontaneous circulation back. The optimal compression depth was just under 5 centimeters. And same thing for survival to hospital discharge. The optimal compression depth was just a little bit over 5 centimeters. And what they found in general is that any compression depth over about 4 centimeters or 38 millimeters produced an odds ratio of 1.91 of survival to hospital discharge, meaning that if you have compressions of greater than 38 millimeters across the board, you're twice as likely to survive. So it's a really important variable and a really easy one to optimize. This graph is about chest compression fraction. So in this study, they looked at the percentage of time in the overall cardiac arrest that the patient had active chest compressions being performed. And they stratified according to the percentage. So 0 to 20, 20 to 40, 40 to 60, et cetera. And they found, not surprisingly, a linear increase in the likelihood of return of spontaneous circulation as the chest compression fraction increased. So if you spend more time during the code performing CPR, you're going to get a better outcome and a higher probability of survival. This is the same data, but this is actually a survival curve rather than the group stratified data. And once again, chest compression fraction of 0.8, 0.9, or 80 to 90% of the time produce the highest likelihood of return of spontaneous circulation. In another study looking at chest compression fraction, the outcomes were a little bit different. In this study, they found that actually a 60 to 80% chest compression fraction produced the highest odds ratio of survival to hospital discharge, and that's what the current guideline recommends. So you want to be at a minimum of 60%, ideally closer to the 80% range for your chest compression fraction. The bottom line, though, is you're clearly never going to know numerically what your fraction is during the course of a resuscitation. Is a physiologically important variable, but there's actually no human studies on it that demonstrate improved survival because it's kind of a difficult phenomenon to study. But basically, the idea is if you lean on the chest in between compressions, you're going to increase the patient's inner thoracic pressure, right? You're smashing down on the chest, so that's going to raise the inner thoracic pressure. Well, we all know that positive pressure ventilation also raises the inner thoracic pressure. So if you cram more air into the lungs, you're going to raise the thoracic pressure. And the bottom line, what brings blood back into the heart during diastole? It's negative inner thoracic pressure, right? It's that negative pressure gradient that pulls blood from the periphery back up to the heart. So if you raise the inner thoracic pressure and make it not negative, you're going to prevent the heart from filling, and you're going to decrease your cardiac output by decreasing your stroke volume. The ultimate effect, again, is going to be impaired cardiac output, and that means less blood flow to the heart itself, less blood flow to the brain, and less likelihood of spontaneous circulation. So, bottom line, high quality CPR is what you need to do to optimize your chances of survival. And the determinants, once again, are push hard, 4 to 5 centimeters, push fast, 100 to 120 compressions per minute. Keep it going. You want to make sure your chest compression fraction is a minimum of 60%, if not more, during the course of the arrest. And avoid hyperventilation and chest wall leaning. If you do those 5 things, you're going to increase your patient's odds of survival. So, once you have really good quality CPR going, what's the next question you need to answer? You've already decided your patient is pulseless. You've already initiated compressions. What do you need to know now? The answer is, of course, what is the cardiac rhythm? And specifically, is it a rhythm that we can treat with electricity? Is it a shockable rhythm? So, shockable rhythms, like we said before, are more likely to survive. Patients who can be shocked are more likely to live through a cardiac arrest. But defibrillation is a very time-sensitive intervention, meaning the faster you do it, the more likely it is that your patient's going to benefit from it. So for shockable rhythms, we consider defibrillation to be more important than anything else you can do, more important than CPR, more important than ventilation, more important than drugs or IV access. It is the single most important thing that you can do. So if you have a shockable rhythm, you need to know early and you need to treat it early. Here's one of our shockable rhythms. This is ventricular fibrillation. It's very easy to identify. It's randomly fluctuating. It goes up and down. There's no pattern. There's no rhyme and reason. There's no QRS complexes. It's just a disorganized squiggle. The second one is ventricular tachycardia. Now, in VTach, there actually is organization to the QRS complexes, but they're wide and bizarre looking. So anytime you have a fast rhythm with wide QRS complexes, you should suspect that to be ventricular tachycardia. And by the way, these are the 2 rhythms that the automated defibrillators that you see in So why do we only shock VFib and VTach? This frustrates a lot of students because you see on TV, everybody in cardiac arrest gets shocked and they all jump up and come right back to life, right? Well, it doesn't work that way in the real world because the whole goal of using electricity is to reorganize a rhythm that is disorganized. Now, when you are in a non-shockable rhythm like PEA, you have some major problems on the table, but electrical disorganization is not one of them. It's not an issue for patients in non-shockable rhythms. And at best, if you go and shock a non-shockable rhythm, nothing will happen. At worst, you could potentially hit the patient at the wrong point in the cardiac cycle, cause an R-on-T phenomenon, and ultimately precipitate a dysrhythmia like ventricular fibrillation. So the last thing you want to do in a cardiac arrest is take somebody who has a normal rhythm and turn it into VFib. That's clearly not benefiting anybody. So we don't perform defibrillation for any rhythm except our 2 shockable rhythms, VFib and VTach. I mentioned before that defibrillation is a time-sensitive intervention, and this graph clearly shows why. So as you can see, the more time that elapses as we move along the axis there, the lower the likelihood of survival for the patient. So for patients in shockable rhythms who are getting shocked within the first minute, you can see 35–40% of those patients are surviving. But by the time we get out to 6 minutes, it's less than 20% of the patients surviving. So we really want to make sure that as soon as we're humanly able to do so, we assess the rhythm and we defibrillate if we identify a shockable rhythm. Again, short time to defibrillation, high likelihood of survival. And as we go down to 2, 3, 4, 5, 6, and more than 6 minutes, you can see that the odds ratio, or the likelihood that the patient is going to survive the event, goes down consistently with every minute that passes. It's this quickly. All right. Now, once you've gotten your high-quality CPR going and you've assessed your rhythm and defibrillated if it's indicated, what do you want to do next? Well, this is when you can start thinking about respiratory support for your patient. So you can initiate bag valve ventilation in order to give your patient some oxygenation. You want to also coordinate your chest compressions with your breathing. So you're going to do 30 compressions followed by 2 breaths, 30 compressions followed by 2 breaths. You also, if you're in a hospital setting, are going to establish vascular access, and you're going to continue reassessing the rhythm every 5 cycles or 2 minutes for the duration of the resuscitation. Now, a lot of students ask me, Dr. Young, this is all great, but this is like basic stuff, right? What about the cool stuff like putting in airways and pushing drugs? Well, unfortunately, advanced interventions in cardiac arrest don't really make much of a difference. This is a study that came out of Scandinavia that really showed whether you're performing basic life support or advanced life support, your outcomes are very similar. So in these two cases, you can see the red line represents patients who got no IV access, no IV drugs, and no advanced airway interventions. And the green line represents patients that did receive those interventions. And you can see how very similar the outcomes for both groups were. So bottom line is that CPR and defibrillation is by far the most important element of your resuscitation. And all the advanced stuff really doesn't make as much of a difference as we'd like. So let's get back to our case. So we have our 58-year-old guy who collapsed at a sporting event. What are we going to do for him? Well, like we already said, 1, we're going to call for help as quickly as we can. 2, we're going to think CAB, so we're going to go to him and we're going to decide whether or not he's got a carotid pulse. If he doesn't, we're going to go ahead and initiate chest compressions. And then once we can get access to a defibrillator, which hopefully at a sporting event would be pretty quickly, we're going to put it on, assess the rhythm, and defibrillate if, of course, it's indicated.
Okay, before we proceed to the next part, let's have the open room muna in case na may mga questions po tayo. Questions po. We will be entertaining questions now. Questions? Ma'am Joy. Questions po from the students or from the trainees po, sorry. Tanong po. Okay, if wala, then I'll be showing you a video na po on the sequence how to perform high quality chest compression.
Before anything else, pause and assess the scene for hazards. If the situation is dangerous to you, do not approach. If it is safe, quickly assess for responsiveness. If unresponsive, activate EMS and send someone to get an AED. Check for normal breathing. Do not be fooled by gasping actions. If not breathing or only gasping, begin compressions at 100 to 120 times per minute. Remember that quality matters. Push hard and push fast. Do not lean on the chest. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing CPR cycles of 30 compressions and 2 rescue breaths.
Okay. Yes po, that video guys was before COVID. However, pag nag-COVID na kasi or nung pumutok na po ang COVID natin na problem, no need for you to give na yung mga artificial airway po natin, but instead, we can make use of the BBM. Diba? We need to limit kasi yung mga aerosol generating na mga na mga methods such as yung ginawa ni care provider kanina na kung saan gumamit po siya ng one-way valve, which is a big no-no during the time of pandemic na. So again, ang gagawin po natin is of course the HEPA filter with the use of the BVM. So my next topic will be more of the COVID na po kasi i-apply na natin COVID and the BLS. Now, sa COVID kasi na time guys, na meron silang tinatawag na LUCAS. LUCAS is of course a parang equipment po. Parang siyang machine na high-tech siya na kung saan malilimit po ang exposure ni nurse. Kasi siya mismo ang magko-compress na kay patient. Pero before ko ipapakita yung video ni Lucas, gusto ko ding ipakita kung ano ba ang nasa COVID. Okay po? And what to expect, what are the symptoms ba sa COVID? And then what are the protocols na ginagawa po ng isang frontliner? So again, video presentation po tayo.
This is SARS-CoV-2. It belongs to the family of coronaviruses named for the crown-like spikes on their surfaces. SARS-CoV-2 can cause COVID-19, a contagious viral infection that attacks primarily your throat and lungs. What actually happens in your body when you contract the coronavirus? What exactly causes your body to develop pneumonia? And how would a vaccine work? The coronavirus must infect living cells in order to reproduce. Let's have a closer look. Inside the virus, genetic material contains the information to make more copies of itself. A protein shell provides a hard protective enclosure for the genetic material as the virus travels between the people it infects. An outer envelope allows the virus to infect cells by merging with the cell's outer membrane. Projecting from the envelope are spikes of protein molecules. Both a typical influenza virus and the new coronavirus use their spikes like a key to get inside a cell in your body, where it takes over the cell's internal machinery, repurposing it to build the components of new viruses. When an infected person talks, coughs, or sneezes, droplets carrying the virus may land in your mouth or nose and then move into your lungs. Once inside your body, the virus comes in contact with cells in your throat, nose, or lungs. One spike on the virus inserts into a receptor molecule on your healthy cell membrane like a key in a lock. This action allows the virus to get inside your cell. A typical flu virus would travel inside a sac made from your cell membrane to your cell's nucleus that houses all its genetic material. The coronavirus, on the other hand, doesn't need to enter the host cell nucleus. It can directly access parts of the host cell called ribosomes. Ribosomes use genetic information from the virus to make viral proteins, such as the spikes on the virus's surface. A packaging structure in your cell then carries the spikes in vesicles which merge with your cell's outer layer, the cell membrane. All the parts needed to create a new virus gather just beneath your cell's membrane. Then, a new virus begins to bud off from the cell's membrane. Now, with the virus spreading in your body, how can you develop pneumonia symptoms? For this, we'll have to look into your lungs. Each lung has separate sections called lobes. Normally, as you breathe, air moves freely through your trachea or windpipe, then through large tubes called bronchi, through smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Your airways and alveoli are flexible and springy. When you breathe in, each air sac inflates like a small balloon. And when you exhale, the sacs deflate. Small blood vessels called capillaries surround your alveoli. Oxygen from the air you breathe passes into your capillaries, and then carbon dioxide from your body passes out of your capillaries into your alveoli so that your lungs can get rid of it when you exhale. Your airways catch most germs in the mucus that lines your trachea, bronchi, and bronchioles. In a healthy body, hair-like cilia lining the tubes constantly push the mucus and germs out of your airways, where you might expel them by coughing. Normally, cells of your immune system attack viruses and germs that make it past your mucus and cilia and enter your alveoli. However, if your immune system is weakened, like in the case of a coronavirus infection, the virus can overwhelm your immune cells and your bronchioles and alveoli become inflamed as your immune system attacks the multiplying viruses. The inflammation can cause your alveoli to fill with fluid, making it difficult for your body to get the oxygen it needs. You could develop lobar pneumonia, where one lobe of your lungs is affected, or you could have bronchopneumonia that affects many areas of both lungs. Pneumonia may cause difficulty breathing, chest pain, coughing, fever and chills, confusion, headache, muscle pain, and fatigue. It can also lead to more serious complications. Respiratory failure occurs when your breathing becomes so difficult that you need a machine called a ventilator to help you breathe. These are the machines that save lives and that medical device companies currently ramp up production for. Whether you would develop these symptoms depends on a lot of factors, such as your age and whether you already have an existing condition. While this all sounds scary, the push to develop a coronavirus vaccine is moving at high speed. Studies of other coronaviruses led most researchers to assume that people who have recovered from a SARS-CoV-2 infection could be protected from reinfection for a period of time. But that assumption needs to be backed by empirical evidence, and some studies suggest otherwise. There are several different approaches for a potential vaccine against the coronavirus. The basic idea is that you would get a shot that contains faint versions of the virus. The vaccine would expose your body to a version of the virus that is too weak to cause infection, but just strong enough to stimulate an immune response. Within a few weeks, cells in your immune system would make markers called antibodies, which would be specific for only the coronavirus, or specifically its spike protein. Antibodies then attach to the virus and prevent it from attaching to your cells. Your immune system then responds to signals from the antibodies by consuming and destroying the clumps of viruses. If you then catch the real virus at a later stage, your body would recognize it and destroy it. In other words, your immune system is now primed. Collecting evidence on whether this will be possible, safe, and effective is part of what's taking researchers so long to develop a vaccine. It's a race against time to develop a vaccine amid a pandemic. Each step in vaccine development usually takes months, if not years. An Ebola vaccine broke records by being ready in 5 years. The hope here is to develop one for the new coronavirus in a record-breaking 12 to 18 months. While all this will take time, stay home if you can, to protect the most vulnerable. And don't forget to wash your hands for at least 20 seconds and as often as possible. This video was a collaboration between Nucleus Medical Media and the What If channel, where we usually dive into hypothetical scenarios about the human body, humanity, our planet, and the cosmos. Check out our channel by visiting the link.
This is Sir Lucas na ano po.
Dave, are you all right there? Dave, can you hear me? Can you hear me? Can I have some help in here, please?
Hi Zoe, what's wrong?
I don't think Dave's breathing properly. 2222 and ask for the adult team. Get the resuscitation grab bag, the resuscitation trolley, and the Lucas, please.
Okay, I'll go and do that.
Thank you. Thanks.
Apply pads. Plug in pads connector next to flashing light. Stay clear of patient. Analyzing. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock.
Shocking.
Shock delivered. Begin CPR.
Okay, sit the patient forward. On 3. 1, 2, 3.
On side.
Happy with position?
Yes.
Okay, turn the Lucas on. Okay, 1,
Okay. Down.
2. 30 to 2.
Stay clear of patient. Analyzing.
Okay, Emma and Zoe, you get changed to PPE gear. I'm Caroline, I'm going to be team leader.
I'm Oliver, I'm the anaesthetist.
Lovely. I can see a shock has been delivered. Are you happy to intubate?
Yes.
Jane, will you be happy to help and pass me the blue box, please? I'll pause the Lucas when you're ready. And when you have a free hand, Jane, will you pass me the blue box?
Yep.
Looking at the AED, we've had 1 shock delivered already.
I'm ready to intubate.
Okay, so Lucas on pause. The rhythm is non-shockable.
True, please, Jen.
Okay, that's the HEPA filter. The viral filter po. Tapos
Patient
no
intubated.
connects.
Okay, we're going to go back on to 30 to 2.
Ay, sorry. Ag at saka ano. Ag 2.
I will time the 2-minute cycles. Thank you, Jane. I'll give some adrenaline. 1 in 10,000. The adrenaline in.
Okay. Ayan, questions po regarding sa video po natin. And kasi my last topic po will be yung sa ano po natin, sa HEPA filter po natin. So this will be my last topic na before kayo magki-quiz. And that's where the HEPA filter setting up.
Okay, we're building a bag valve mask setup intended to decrease the amount of virus in the air. What we need for this is our mask, we need our end-tidal CO2 sampler, we need a PEEP valve, our bag, and we need a viral filter. So these are 3 viral filters, 2 different brands. These 2 have a bonus humidifier in them. We can use any of the 3. So we'll take our mask, we'll connect the viral filter directly to it. Next, we will connect our end-tidal CO2 sampler, and we'll connect the bag to that. Now we'll take our PEEP valve and we'll connect this to the exhalation outlet. Now that we have this all connected, we have a viral filter connected directly to the mask, and this will effectively separate inhalation and exhalation so that on inhalation, oxygen flows from the bag and the reservoir into the patient. On exhalation, it flows in this direction. The PEEP valve, as we have it, is set to 0. When it's set to 0, it acts as a one-way valve, so it effectively separates inhalation and exhalation and can be used to pre-oxygenate the patient in place of a non-rebreather mask or other mask.
Okay. Ayan, so at this point in time, no, so magki-quiz na po kayo, mag-exam na po kayo with your BLS, and then usually for 1 hour kasi yung exam natin, and then we'll give you time also to celebrate then the Mother's Day. For sure, yung iba kasi magla-lunch pa, no? And then we'll resume po at exactly 12:30 p.m. So okay lang po ba? Can I see a thumbs up sign or a heart reaction if ever kung okay po sa ating agreement? Ayan, so mag-i-exam na ha. Yeah. Tapos magse-celebrate siyempre ng Mother's Day. Minsan-minsan lang mga celebrations na 'to and we need to celebrate life din talaga. Okay po? Kasi kami magla-lunch din kami. So, I'll see you po. So, magki-quiz na. Ma'am Wipam admin. Ma'am. Okay, standby ha. Magse-send po sila ng link na for your examination. Sige po. Standby. Sige po. Those po ng mga bago. By the way, I'm Mark Adlawan. I'll be your ACLS instructor. So, at this point in time, we will begin po with our ACLS. And then to begin, let's have the video presentation from the American Heart Association about acute coronary syndrome or the heart attack.
fine. I think Leticia,
Hey, Jack, what's up?
happy Monday. When you finish with this, I need you to clear off the end cap down there. I got a whole bunch of promotional items coming in. We got to put them somewhere.
Okay, sounds good.
Oh,
You all right, Jack?
yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Okay.
Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTEACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
I think Jack's having a heart attack. I'm gonna call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency?
I think my manager's having a heart attack.
I see you're located at 459 Commerce Avenue, is that correct?
Yes.
Where is the patient?
He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago, and when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 160 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved no history of true intestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive. Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No.
Have you had any bleeding in your stomach recently?
No, I don't think so. No.
No to both questions.
Look in the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That
so good. It's my chest. I feel like somebody's squeezing it.
Okay, well, we're gonna help you out, reduce that pain. I'm gonna get a 12 lead. Go ahead and get his blood pressure and put him on pulse ox.
When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation, my highest priority is to obtain a 12-lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poorer the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital. So I follow the ACLS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12 lead electrocardiogram.
Looks like a STEMI.
Segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
The patient had ongoing symptoms of ischemia, so we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses. 3 is the max. We monitored the patient's blood pressure in between each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypotension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics such as morphine while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. Current vital signs are BP 104 over 7. Pulse ox 95%. He shoots 325 milligrams of glycerin sprays. This says 12 lead shows ST segment elevation of 3 to 4 millimeters in leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead and your initial report. We'll activate our heart alert system, contact the cardiologist and the cardiac cath team. We'll see you guys in a few minutes.
Let's get ready.
Get real treatment of these. Lab prepped and ready. By the time the patient can
The American Association and the closest appropriate facility that provides reperfusion without delay.
Hi, sir. I'm Dr. Taylor. We're going to take good care of you today.
After we last talked, his pain is down to 2 out of 10. Otherwise, he's stable.
Let's get him to bed.
Right. Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing the 12 lead that the medics had sent, I immediately activated the PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the knee rhythms, include PCI within 120 minutes after the first medical contact, or fibrinolysis within 30 minutes. The appropriate therapy patient and
within the first 10 minutes after arrival, the ED staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a early ECG shows no signs of ST segment elevation. Then a repeat ECG in the ED is warranted. Staff should also draw the STEMI panel. I've activated the STEMI pager and get him to the cath lab as soon as they're ready.
Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, I'm Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so, but his vitals are improving, and we're moving him to the cath lab. This is going to allow us to see inside his heart and his arteries and treat it as well. Dr. Abrams is an excellent cardiologist, and he'll be helping you through the next steps. You'll be in good hands with him, okay?
Thank you.
This patient presented with ST segment elevation of 3 to 4 millimeters in leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI, when patients meet the 120-minute window from first medical contact or 90-minute window from ED arrival to balloon inflation in the catheterization lab.
Hi, Mr. Brennan, I'm Dr. Abrams, your cardiologist. How are you feeling?
Not so good.
Well, hopefully you'll be feeling a lot better soon. I just want to talk to you a little bit about what's going on. I've reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that'll help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the blocked area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart. Okay?
Okay. I understand. I'm ready.
All right. Well, let's see what we can do to help you get better, okay? All right.
PCI opens the blocked artery with a tiny balloon. Then a stent, or metal scaffold, is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together, and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all work.
Ayan. So good afternoon po. So more of the pharmacology na po tayo. Ayan. We pump main. Okay lang po bang gawin akong co-host? In case lang po, let's say, di ba, napindot nila yung mga mics po nila. Ayan. So if ever po kung ongoing yung discussion po natin, be ano na lang po, be mindful na lang din sa ating mic na dapat naka-mute po sila. Okay po? Kasi yeah, minsan hindi po natin alam na naka-on pala yung mic po natin. Kasi yung iba first time din na na mag-online, like the online platform, okay po? Ayan, sige. So let's have the ACLS. Basically guys, pag sinabi po nating ACLS, it's the Advanced Cardiovascular Life Support. And when we say ACLS po, ayan, ano ba yung highlight natin dito? This is a combination of your BLS plus your medication. So we have the BLS here, plus meds na, plus intubation or endotracheal intubation po natin, or the endotracheal intubation, ET intubation natin.